First of all, thank you to Balazs for inviting me and arranging for me to have a window seat on the plane, and I managed to get that picture as we came in, which hopefully might get a chance to visit as well. I didn't know the work of Janez Faganel before I had a look at it all, and actually there's some very, very interesting papers, and I'll be mentioning interneurons later, so look out for that, because I think actually that paper is worth a read and reminds us of some key anatomy in the spinal cord, which may well be involved in ALS. So I always think when we're talking about biomarkers in ALS, the really amazing thing about ALS is that you can go to an old article like this from 1894. In those days, it didn't seem to matter if you put the person's name and their address and where they lived. But you can look at that and you can read it, and there's absolutely no doubt that it's ALS. And there aren't many conditions in neurology where you'd be so sure. And so you pick out the key things. I'm actually quite interested in the fact that our patients do seem to be quite fit and well. I won't talk much about that today, but it's definitely something of interest. I don't think it's bad for you to be fit and athletic. I don't think it's a cause of ALS, but I think there's something in that association. Often patients will talk about sensory change, but they don't mean that. They don't mean their leg has lost sensation. It's the progressive weakness, foot drop, bad sign really in someone who's previously very well without any sensory involvement. Wasting, and then the progression, and then sometimes this particular pattern quite often of the lateral part of the hand. Exaggerated reflexes, and the sensation largely unaffected. And then we might observe the muscle fasciculation, which really... So if you read that story in a referral letter, I mean, actually, I think if the signs on examination were there, I'm not sure you'd need to do any investigations whatsoever. And that's really important because we need to be careful about what we're trying to do with biomarkers. What do we know with ALS? Well, we know that it has this rather focal symptom onset, generally 30% bulbar, upper limb or lower limb. There's a relative sparing of the eye movements and the bladder that's been looked at for years. And my own sort of thoughts on that are probably less molecular. I think we haven't really thought enough about the architecture of the nervous system. And I think, a two-neuron circuit like the motor system, eyes and bladder are a little bit more complicated. They have different resting states of firing. I think that some of those factors may be much more important in why we see that resistance. I'm less drawn to the idea of some difference in receptors or chemistry. And the question is, does it start in the brain? Does it start in, peripherally? I don't know. I've never really liked the idea that it starts in the muscle and tracks backwards. I don't think we can be dogmatic about starting in the brain, but I think there's definitely, as I'll outline, there's definitely a brain process. So we get this complex condition of upper and lower motor neurons, lots of signs there that you'll recognize, the muscle wasting, the tongue fasciculation we might see. We can see more complex brainstem-mediated processes like emotionality. And we're recognizing this frontotemporal involvement, which leads to changes in behavior, insight, risk aversion, and actually changes in eating habits as well, with a lot more sweet food. And all of this adds up, channels through the respiratory system to mean that this is a condition that usually has a median survival of about 30 months. We get this complex mix of lower motor neuron and upper motor neuron involvement, lots of wasting in this patient, really just atrophy of the motor cortex in these very pure upper motor neuron PLS patients. And we call that ALS. It's a mixture of the two. But if we bring in the frontotemporal involvement, we get some very, very nasty progressive disease here, which may run its course really in less than a year. What are the obstacles? Well, I'll talk a little bit about our need to get earlier diagnosis. We know that that is a year on average. Heterogeneity, big problem, and that's another reason that we want to stratify patients. The one I really want to focus on is how you measure change. How can I tell, if I'm going to try a drug, that this person is getting better? That's a very high bar, but how can I, at the very least, tell that they're getting worse more slowly? And they're not going to be able to tell usually, and I need to be able to tell to make sense of the drug. I won't talk a lot about this, but I will mention at the end about our efforts to look at who's at risk, and that's largely come from genetic carriers. So let's talk about diagnosis, because it's going to take about half an hour, or, well, really, in a specialised ALS clinic, it's going to take about 5 minutes to make a diagnosis of ALS. And so the problem is they've taken a year to come to that clinic. And that's because they won't think there's something wrong early on. Their primary care physician, it's all very well to talk about a test for ALS, but if the primary care physician doesn't think of ALS, they won't know to do that test. And if they do it on everyone, the chance of it being ALS is 0, really, most of the time. So we have to accept, really, that some of this isn't reachable. And one of the problems is people getting sent to the wrong specialty, getting sent to the ENT surgeon for their bulbar problems or stroke clinic. And we know that the faster you come to see a specialised neurologist, unfortunately, the worse your outcome. And that's simply because it's a surrogate marker for how aggressive your disease is. It's very obvious if it's rapidly progressive bulbar ALS. It's not fooling anyone. The more difficult cases are going to be the ones where there's a very slow presentation, perhaps one limb at the start. And, you know, I love the historical literature, and it's all in this picture here from 1943. Everything that we know now, we think we're very clever. But, you know, it's all here. This is showing that there's extremes of upper motor neuron, called PLS here, and lower motor neuron, which used to be sort of termed PMA. I think I prefer upper and lower motor neuron predominant ALS. And the Charcot type, the sort of mixed type in the middle. And look here in this bar here, this is the speed of progression. And it gets slower as you come out towards PMA and as you come out towards PLS. So when you get predominant lower or upper motor neuron, when you get a slower rate of progression or one region, they're the really difficult ones. And we know that there is a role for biomarkers there. I don't give everyone trials of immunoglobulin. I don't know if there are trainees in the room, but I think it's an important point. There's really no need to do that. EMG you're very familiar with. We don't do our own neurophysiology in the UK. I wish I'd been trained in it, but we don't get trained. And we recognise these sorts of findings. It is operator dependent. And so these sorts of potentials, sharp waves and changes in recruitment pattern, they're only 60% sensitive. And many of you who do your own neurophysiology will have seen patients with very clear bulbar involvement and no abnormal findings, even in the tongue. So we know those patients get delayed, they get told that they thought it was ALS, but it's not because the EMG is negative. And of course, that's not the wrong way around. If it looks like ALS, it's ALS, and bulbar onset, there's very, very little else that will look the same. We had all these criteria, and what I found operationally difficult, you don't need to read all of this, but these are the original ALS criteria, these were the modified ones. Operationally in the clinic, you can't say to someone that they've got possible, probable or definite ALS, because all they're listening to is if it's not definite, they'd like to see a neurologist who can tell them properly. So possible doesn't mean anything. People die with possible ALS because what it means is you've got limited regional mixed upper and lower motor neuron involvement. These were research criteria. They were very, very unhelpful in the clinic. And we met, well, I just want to point out, actually, just before I meant the Gold Coast criteria, we know the trajectories are very different of survival. Here's Lou Gehrig with a very typical trajectory. Here's Stephen Hawking with a very unusual one. And, you know, in these models, if you put a 20-year-old with leg onset, that's Stephen Hawking, if you put him into the probabilistic model, it will say that there's a 20% chance that that individual will live to the age of 70. So we know that there are exceptions. I totally take the point I was discussing with a friend last night, that he's really out there. But, you know, I think we can all agree that there's progressive muscle wasting. The interesting thing is that in my small series, upper motor neuron signs do not change over time. If you've got a lot of upper motor neuron involvement, it stays that way. And if you've got very little, it stays that way. So why did we build ALS criteria obsessed with having more and more upper motor neuron signs to get to definite when that doesn't happen? So we met in Gold Coast, and the idea here really is to come up with something a little bit simpler. It's not perfect, but something to get people into studies, because we generally know when it's ALS. We don't want to use words like possible, probable. We want to get people, it's ALS or it's not ALS. I won't go into the details, but it's a little bit more flexible, one body region, but still with mixed signs, or you have to have two body regions with lower motor neuron signs. But I think the idea was to make it a little bit more permissive and the language of ALS or not ALS. What would we really like? We'd like the unifying signature, which is this molecule TDP43. This is our amyloid for ALS. It should be in the nucleus. It moves out into the cytoplasm normally. It's back and forth. It's into the mitochondria, actually, and back out. That's happening all the time. But it aggregates and then doesn't work and is found in the cytoplasm here, aggregated. And that is the hallmark. That's the tombstone of the neurons of ALS. And we find that in 97% of all cases. Now, the scientists, all of you in the room, will say, well, tell me about the 3%. And, of course, that's SOD1 and FUS, and I'll talk about those later. And if you put a FUS or an SOD1 patient in the clinic alongside the other cases, you wouldn't be able to tell the difference. And so we've still not got a biomarker that's absolutely unifying. But if we could come up with something that would reflect that pathology, that would be the ideal biomarker. The genetic complexity is rising. This is from the SOD1 discovery in 1993 through the discovery of mutations in the gene for TDP43, although that's a tiny, tiny proportion of cases, exactly the same as presenilin is a tiny proportion of Alzheimer's, and alpha-synuclein gene mutations are a tiny proportion of Parkinson's. And that's telling me that these genes are extremely important for normal development. And so actually mutations in the vast majority of those mutations are just not tolerable from birth. But it's interesting biologically. FUS came later, another very rare cause, and then, of course, the C9 or ORF72 hexanucleotide expansion, which can also cause FTD. This is the picture, really, of how we understand it. This is a sort of analogy of a river, really, flowing from upstream. Most cases, a mixture of genes and environment. Most cases coming through TDP43 pathology, mostly into ALS, but from some of the genes, but in C9 ORF72, will dichotomize largely into one or the other, or sometimes both. TARD BP comes through here, but then SOD1, they come underneath, outside the TDP43 realm, as does FUS, and PLS really doing its own thing here. So a common set of pathways here that we might target like cancer in the same way we use things like radiotherapy, something that targets the core pathology, but upstream we're going to be needing to use much more gene-selective treatments. You rely on people coming to clinic to tell you they've got a family history of motor neuron disease. It won't be very many. Most of them will have the expansion C9, the rest SOD1, a tiny proportion here. And in a third of families, where you can see in every generation that they're getting ALS, you will not be able to tell them what the gene is. You'll be able to say there's a dominant risk and your children have a 50% risk still, but we can't find the gene. And that missing heredity is a massive problem, actually. And I'm not a geneticist, and I ask smart people who are, and they don't know where it's lying, and they don't know where it's hidden. There's obviously something much more complex in DNA that we're missing at the moment. But if you go to people who don't have a family history, you're going to find 7% of them with an expansion. And if you do the maths on that, 10% of that 90%, so 10% of these people without a family history is more than 70% of the people with a family history. So there is now no question every person diagnosed with ALS should be offered a genetic test, should be offered one. Because the yield, you will pick up cases, and now that treatments are coming through, we need to know. So that's a real overnight change, actually, in the last couple of years. We don't really talk about familial and sporadic ALS. It's a condition that has a monogenetic component in a large number of cases, or a significant number, and so offer them a test. We tried a lot of drugs, riluzole, edaravone. This is the Amylyx compound, the bile acid and sodium phenylbutyrate. It's probably the bile acid that does the work. Interleukin-2, we don't know yet. We haven't seen the data. But all these other things been tried and failed. So there's the biggest barrier. It's that measurement of change that's the problem. We've got lots of drugs to try, but to put them in a phase 3 study requires time and money. And so we must use the drugs that have the best signal. So we need to look for markers, and I've spent 20 years looking at brain, looking at spinal cord, using TMS, looking at some of the downstream markers as well, and increasingly looking in biofluids. And I'm going to just talk you through a little bit about each of those. So I started off very humbly with this Biomarker study. I have to have a good acronym. I kind of very naively thought that there'd be a real obvious signature in the brain, MRI signature of ALS. And, for a catastrophic condition that was taking somebody's life in 2 to 3 years, it's amazing how little you can find. The blood tests are normal, the brain scan looks normal, sometimes the EMGs are even normal. So this is a very, very tough nut to crack for biomarkers. But we got people in and we started looking at them longitudinally and doing lots of tests, and that's become a kind of model that many diseases have taken on, and it's become much more industrialized, really, and part of the architecture of the clinic. So people want to come in and have a mixture of care and then also give samples, and that works very well. So there's been a revolution in imaging, a pointless, frivolous video there of me building a Lego MRI scanner. But we can talk about structure and function, and really we've used computing as a way of objectively measuring changes in brain atrophy, looking at white matter structure using something called DTI, and looking at functional changes. These are the coherent signals of blood oxygenation across parts of the brain, accepting really the brain is not just about wiring. It has a kind of almost wireless component, really, where you can't always just say that bit's doing this and it's independent. It's working at a network level. And although that's a rather nebulous hand-waving term, it absolutely is probably the key to understanding brain function. We're probably moving into a post-simple connectomic level, actually, into something much more transcending into networks. So the structure, we are able to do pathology much more in vivo, and early on we were able to show some of these changes in the callosum and corticospinal tract using DTI. And we can see that back in 1960, Marianne Smith was showing exactly the same changes in the post-mortem samples. But we can do this in living patients. The problem is groups of patients is still not at the individual level. When we look at groups, we can see that over time, there's a lot more grey matter involvement, including extramotor structures like the thalamus, particularly in the C9 patients. But a lot of white matter damage by the time somebody's diagnosed with ALS. Not surprisingly, by the time you've got symptoms, you've lost at least 50% of your motor system function. We know that from all other diseases, that the reserve in the body is huge. And so, not surprisingly, we're finding a heck of a lot of damage. And to be fair, this does show up damage that we wouldn't have seen on a standard MRI scan. But it's this group-level problem and its sensitivity to change that causes the difficulty. We've used the MRI to show lower motor neuron involvement, or rather upper motor neuron involvement in lower motor neuron cases. So it has the potential to help us with those difficult lower motor neuron, perhaps single limb cases, but at the moment hasn't translated into the clinic. We've used it to look at some of these emerging cognitive and behavioural impairments, and again, it's telling us a lot about wider brain function. Is it going to be useful in the clinic at the moment? It's difficult to see, really, but it's certainly telling us all about the basic science, and that's fine. We don't have to have everything to be translational. I'm interested, I have been for a long time, in machine learning. It's just a contribution I made some years ago, 10 years ago now, with a mathematician. And I think my take-home from this was we put a lot of people with ALS into a study. We put a lot of healthy people into the study. Now, they could not be more different. Even if you have no medical training, you would be able to tell me which is the healthy person and which is the person with ALS just by asking them a question or seeing them walk or talk. And yet the machine really struggles to separate those, and it needed 13 brain regions to do that. And that's telling us that our tools do have quite limited sensitivity at the moment. It doesn't mean it won't happen, but the patterns we're looking for are increasingly complicated, and we just need to be a bit wary that, as any mathematician will tell you, you can fit a model to anything. And all of you will have seen those crazy correlations with deaths by hanging seems to match perfectly with the spending in the US on science and technology. And it's just simply a correlation. You can overfit models. And I think this is the era we're in, and AI is very exciting. It's not the same as machine learning. It's a more agnostic way to try and find things that you wouldn't normally be able to conceive. But we just need to be careful that we don't overfit things. Excitability is very interesting and has really been a hallmark, and the Sydney group have really led a lot of the work on this. But some very, very important early studies from Japan, however. This paired pulse TMS captures the interneuronal component, particularly in the brain, which normally inhibits the response, and it's reduced in ALS. You get a lot of cortical excitability, which seems to separate it actually from many other conditions. You can sometimes see it occurring just before the onset of symptoms, and of course it's tempting to think that might be driving the disease. I think again, it unfortunately may be a feature of the disease rather than the cause. And again, threshold tracking paired stimulation, very robust, nice studies have been done, but it hasn't caught the fire in clinic. It's still operator dependent. What's the question you need to answer? Most of the time, you're not in doubt it's ALS. So we need to really think about these tools and where they sit in the real world. I like the idea that there is a failure of brakes, as Janez Faganel was talking about these circuits in the spinal cord. I think we haven't looked at these enough. I know Michael Swash, who I've known for many years, he's very interested in Renshaw cells and thinks we need to do a bit more there. But I think, is this the cause of ALS? No, but if inhibitory interneurons are what are really taking the brakes off the motor system and making it vulnerable, then it is worthy of more study. This review has crawled in its citations since 2012, and a real lesson to young people: never put a question as your title, because the answer is always no, and in fact I think the answer is yes. Don't use a sort of slightly weird version of the word interneuronal, because it just never comes up on PubMed. So the title is everything. I've got very good at titles now. What about the lower motor neuron markers? Well, motor unit nerve estimation, interesting. Has it translated? No. Again, quite operator dependent. It's still in the research territory for me. Mameda de Carvalho and Michael Swash, some very nice work with basic information actually from neurophysiology, the neurophysiological index. I mean, I think that does need a bit more testing in trials actually, because it is quite easy to get, and I don't think it's quite run its course, but it's been around a long time and it hasn't really caught the field. Impedance myography, electrical impedance myography, interesting, but again, doesn't seem to have taken off. So what about MEG? Well, MEG is a very, very sensitive. This is someone making a decision about making a movement, and you can see we're operating here over 1,500 milliseconds, very fast. And we noticed in 2017 that there was this failure really of the beta frequency. All of MEG is divided into the frequency of the signals, and the beta frequency is where the action is. It's where the action is in PD as well. But we saw this failure of rebound here. Now, that wasn't a new finding, and there we are 3 years earlier. There's Blaž just very politely telling me that he knew about that 3 years before. So you can see that this was well known about. But it was nice to, one of the most important things you can do in science is, Richard Feynman always used to say, is first of all, you must repeat the experiment that you're interested in. Okay, that is a really important part. A lot of the talks I've heard today, it's been great to hear people saying they've almost apologized for finding what was found before. That's so important. That is a really important thing. So there you go. Blaž was first to find that. We found it 3 years later, and we did cite you. That would have been really embarrassing if we hadn't done. A little bit of data, just because a lot of physiologists in the room. We're doing a bit more with MEG. I do think it's got potential, so we want to try and find a signal throughout the entire nervous system, because this is a system problem. It's not a brain problem. It's not a muscle problem. It's not a nerve problem on its own. It's a system problem. So Katie's been revisiting corticomuscular coherence using a gripper task. And I mean, these data, they're not published, but it does look really exciting, actually. Really, I mean, this separation, my first thing is that's too good to be true, really. You just don't find that in ALS. But if it's real, and Katie's very rigorous, it's very exciting. So we're really pushing on with that, and I hope that we'll be able to verify that and get it written up. And Michael Trubshaw is a student. There's a lot going on in this slide, but it's really hot off the press, so I didn't want to cherry pick it too much. But Michael's a very junior doctor who did a project as a medical school on MEG, got in touch with me and asked if he could come and do some work. So I said, well, why don't you've got 3 months, have a look at the resting state data. And essentially, I think there is a really strong beta frequency marker in the resting state data, which would be very easy to get in patients. It would be very easy to do that. We're seeing an increased connectivity, which we found in MRI actually as well, increased connectivity, not decreased, which is probably compensatory. So there's a couple of things there that really could be quite exciting biomarkers, not necessarily for diagnosis, but we could give drug challenges and see if we're increasing the beta power back up. And one of the exciting things is Michael sort of was looking at the old literature, and this is why you need fresh eyes, really. And he noticed that, you know, beta power tends to go the other way in normal aging, Alzheimer's and Parkinson's. ALS does something different, which is really exciting, actually. So Michael, hopefully a bit of a star of the future. So what do we want to solve in the last 15 minutes that I've got? So, poor track record using cells and mice, very poor track record of those drugs ever helping patients. Lots of pathways. The problem now is when you do, and I do sort of proteomic work, and you do these pathway analyses and you put these lovely diagrams up and you list the pathways. The problem in ALS now, there's no pathway that you can find that you say, and then we knew this study must be wrong because it came up with this pathway. There's a pathway that fits ALS, every pathway fits ALS, and that's a real problem actually, because it means we're at danger of kind of making stories that fit the result. And this is true of many diseases, but you know, mitochondria have been around for 30 years, oxidative stress, microglia and inflammation, axonal transport, motor neurons are very long. These have been around for 30 years, these ideas. And we keep adding new things. Nuclear cytoplasmic transport is the latest, RNA metabolism, liquid-liquid phase separation, the new sort of biophysics of cells. Very exciting things, but you know, we have to be careful really, and we have to be a bit wary that we're not crossing anything off the list. We really have a big problem with that there's no predictor of human benefit, and I'm going to try and persuade you that I think as a small step we can at least start to look at that. Patients have to be in placebo trials. There's no shortcut to that. I'd like there to be. It's a hard one to explain to patients, but they have to take a placebo. We know that from years and years of doing trials. But if you're going to ask someone to spend a year of what may be 3 years of their remaining life to take a placebo potentially, then let's do it with a drug where you've had a very strong indication that there's a human signal. And we want more centres to be doing studies. So neurofilament light chains become very fashionable. That's always a worry, but I do think in ALS it could be a bit of a game changer for us. There's nothing special about it. It's just breakdown of neurons, the scaffolding, as it were. The real advantage is you can detect it in the blood. I can show you a paper by Rosenberg in 1993 talking about raised neurofilament in ALS. It's not a new idea. This is the really new thing, that you can do it in a blood sample. So I'm going to give you some pieces of evidence as to why I think neurofilament light chain is a really good potential marker, a surrogate marker of likely clinical benefit. It is not a normal thing to have. None of us want to have raised neurofilament. It means there's something going on. If your levels are very raised, there is something going on. So there's some really interesting ideas and applications in primary care, actually, screening older people and saying, okay, I don't know what's going on, but there's definitely something, let's send you to a neurologist. That might be quite interesting. But it's not specific for ALS. ALS is still rare. But when we follow gene carriers, it goes up just before you get symptoms. I'll come back to that. These are diseases with an average neurofilament level. And the reason that it's not very helpful at the moment for Alzheimer's here and Parkinson's here is that these are very slow conditions, largely 10 to 20 years. The neurofilament level is a speedometer. It is a rate of progression. It is not how far you've progressed. And so the levels are very low relatively. MS, they're a little bit higher, but not in every patient. But look at the ones where it's highest. HIV dementia, remember that one, because I'll come back to show you some nice data there. ALS, CJD, the levels are very high because for most patients, the loss of neurons, the rate is very high. So it's a rate measure. In ALS, we've done lots of studies. I mean, this isn't actually the best correlation we've found, but it correlates very, very well with your speed of progression in terms of disability. And in the clinic, actually you can tell people if they're on a slow trajectory, it will stay slow. I've been doing it for 20 years and it doesn't suddenly speed up. People don't reach 0 on the ALS-FRS. They only ever get to about 12 or 15. So it never goes to 0. And if it's going very quickly, it will stay quick. There are very few patients that will plateau. If it's going slowly, it will stay slow. And that fits with neurofilament, that the neurofilament level reflects that, but also stays stable. And if you want a biomarker to test a drug on, you need to know what its natural history is. And if its natural history is this individual will stay the same, this one will stay the same, then it doesn't really matter that they're coming in at different levels, reflecting their different aggressivity of the disease. If the group level is falling, something good is happening, okay? Provided you don't put lots of people in who all got a low level, because they make it quite difficult to show. But the stability, slow, medium and fast, the stability, individual patients here in dotted lines, that is an absolute bonus. That is such a great finding in neurofilament, because you know the natural history, therefore when you give a drug, you know what would have happened. And so we can start to think about, dare I say, doing small studies, not proof of concept, or not proof, but without placebo. So a reminder, it's a speedometer, not a rate, not an extent of progression. Neurofilament does not rise as you lose more and more neurons. Where does it go? I don't know, it gets metabolized. We don't need to worry about that. It just does it. It stays the same throughout the disease. Here's a graph of that rising in pre-symptomatic, which we only know from the gene carriers, but it's likely to be the same in all patients. And in fact, there have been some studies of people's blood tests that were done before they developed sporadic ALS, and you can see when you analyse the blood that it does rise. It stabilises, so we want to try and get them here. If we started doing this type of study here, the risk is the natural history is it's still on the rise, and we might be asking the drug to do a lot if it's rising anyway. We won't get a false positive, but we might get a false negative. So we want to capture them in this sort of phase. And a little word, is it useful in the clinic to make a diagnosis of ALS? No, it's not. Let's throw it out as a diagnostic biomarker. It is not a diagnostic biomarker. These people came to the clinic, thought to have ALS, referred to the clinic. Highly selective, of course. Most of them, all of them, neurofilaments raised. But the question I was asking in that clinic was, did they have something else? And all of these people here did have something else, not just, it's not ALS. I actually said, no, you've got this. These ones, I said, well, it's not ALS, but I'm not sure what it is. And you can see still quite a few of those, that's why I still enjoy my work. It's not easy. I can't be replaced quite yet by a computer. But you can see that people with something else still have raised neurofilament. They've got Kennedy's, other different neurodegenerative problems. So studies that show you it has a great rock curve between healthy people and ALS, well, I hope it does. If you cannot tell the difference between someone with ALS and someone who's completely healthy, the rock should be 100%. So let's not talk about diagnostic biomarkers unless you're saying, in the clinic where you're with the people that you really weren't sure just by looking at them, tell me how it performs there. And neurofilament does not really add anything. Okay? There are some exceptions, and we are using it. But it's a really important example of biomarkers are different things for different situations. And in the clinic, telling the difference between ALS and someone who's healthy is not a serious question to be asking. Frankly, if you can't do that from asking a few questions and examining them, then there's a problem. So Alex, one of our consultants now, he was my DPhil student, and Alex is very interested in data modelling, and he did some data modelling with our data from a large national cohort from Sheffield, Oxford and London. And what this graph is showing you, when we talk about power in a trial, it's the ability to detect statistically significant difference between the groups. And you want to be operating really up about 80% power. And to do that, you need, with traditional disability measures, you're going to need about 100 people per arm. But if you model it with neurofilament, you can do it with far fewer people and you get a faster answer. I've told you to remember HIV. Here's some evidence that neurofilament is telling us that a drug's working. If you give HIV patients highly active retroviral therapy, this is back in 2007, their neurofilament levels drop from massively high to undetectable within about 2-3 months. So it just switches it off. Some studies in MS have shown a similar lowering of neurofilament with drugs that do have a disease-modifying effect. We now have some evidence from ALS. It's a very small group of patients, but it's people who have got ALS due to SOD1 mutations. You can give them this antisense drug, and this tells you that if you run the trial for 28 weeks, you won't find anything. You haven't separated the patients on disability. So you might throw it out, and that's why we shouldn't be doing trials for 28 weeks. They take at least a year, and even at a year, and this is open label anyway, even at a year, you're just starting to see the outcome. So this did not make its primary endpoints. Speculatively in this study, they looked at neurofilament. Neurofilament drops dramatically quite early on in the treated group, and then the people who are on placebo, it drops when you give them the drug. And as time's gone on in the open label study, the clinical measures are catching up. So there's a hint not only that tofersen is effective, and I think that actually the data are looking stronger and stronger in a clinical sense, and it has a provisional license on that basis. But the key thing is that neurofilament predicted that, and that's the real key thing. There's no point in a biomarker that takes a year to get an answer. Anything that we put on the table has to give you an answer faster than just watching the patient's disability. So what I'm proposing is, instead of a trial where you do 18 months survival, no one does this anymore. It's just too blunt, and for all sorts of reasons, it's just not capturing the nuance of the condition. Or you do it on disability. This is the ALS functional rating score. These are people with fast track, slow track, and medium track. And the average course is here. You give a drug and you want to see a shift in the slope. To do that takes 12 months, as we saw in that other study. 6 months won't cut it. It just isn't, because of the heterogeneity of the patients. So I'm proposing that you do a much smaller study. Everyone gets the drug. You measure their blood NFL. Drug Y, no, not interested. It's not doing anything. Drug Z, no, it doesn't go in. It's lowering neurofilament. It does not get licensed. That's really important. You don't start giving it to everyone. It's not proven. But you put it back into the proper study. And you say to someone, yeah, we need to do a proper 12-month study. You might be on placebo. But you know what? This time, this drug's giving us the sort of signal we used to see in HIV, that we've seen in MS. This is really promising. And I think people will accept that deal. I think that seems to me to be a better use of our time, money, and their time as well. So the proposal is a project I've called Experts ALS, because it's experimental medicine route to success. I was very pleased with that one. Almost because Ambrosia, actually, I'm quite good at acronyms, if nothing else. So come to me if you need an acronym. So experts will take a drug. It'll take it from a panel who will be looking at preclinical data, looking for off-target effects in repurposed drugs. And there's a whole range of really interesting things. Some drugs that have incredible effects on cells that you would never have predicted because of what they're used for normally. Diabetes, Parkinson's, all sorts of things, blood pressure drugs that are obviously having an off-target effect. And we can put these into a study that we think we can power. The statistics have all been done by modelers. We can power it over 3 to 6 months, maximum 6 months, anything from 20 to 50 patients, because it's a dynamic Bayesian model of NFL. So that if the readout's coming through very early that it's going up, we stop, move on. The most likely, of course, is the readouts just staying the same, and that might take 50 people. It might take 6 months to be certain. But obviously, we hope for these ones. And the important thing is that you don't then say, oh, we found a drug for ALS. That's overreaching the science. This is non-placebo controlled. But they get prioritized for these platform phase 3 studies. So in the last 5 minutes, just a little bit about pre-symptomatic stuff. We know there's a lot going on before you get symptoms. It's true of any disease. And what's happening probably is you've decompensated what you were able to manage for 50 years of your life. So you're carrying a C9 expansion. The real question is, why didn't you get problems early on? Well, maybe you did, actually, and I'll show you some data on that. We'd like to give our release on, instead of giving it here, we'd like to give it here, or better drugs. So there is a lot going on in the brain before symptoms. We know in the C9 carriers, the brain, lots of structural changes many years before the onset of symptoms. Lots of functional changes. These are the patients affected patients with ALS. Green is the controls, and you can see the gene carriers falling somewhere between the two. Similarly, in MEG, we got a lot of changes in ALS versus healthy people, as you would expect to. But we also get some changes in gene carriers versus healthy people. And that's a more interesting comparison, healthy versus gene carrier asymptomatic, because they do feel healthy, and so it's a reasonable comparison. Lipids are changing decades before you get ALS. Looking back over GP records, this is LDL cholesterol, LDL-HDL ratio is very different in people who go on to get ALS. In a multi-million population study, 600 people who went on to get ALS had a different LDL-HDL ratio for years before. What does that mean? We'd never have thought of those markers. We're going to have to be much more agnostic and not look for markers that we find in the disease state, and not try and fit markers like lipids into things we know about in the disease state, and just say maybe this is a bystander effect of something else that's going on. So some very interesting data on lipids, and a new trial really, where you take the gene carriers, you wait for their neurofilament to hit this level, and then you randomize them to that drug, tofersen. So we're bringing the window back even further and giving the drug our first prevention trial. This is the ATLAS study, really exciting, very difficult to run, very difficult to organise. Michael Benatar's really driven this with Biogen, but we're bringing it back to earlier time points. And then what do we see when we look at the C9 carriers? Well, the Dutch group have really led the way on this, and what they're seeing in the brains is really quite game-changing, I think. We need to be careful with our language for families and patients talking about neurodevelopmental problems, because actually people function totally normally in life, but their brains are not normal. It's very clear their brains are not normal from an early stage. And what these measures are showing you, the carriers are starting off, or at least earlier, 20 years earlier, are coming from a different place from people who aren't carriers, patients who aren't carriers, or healthy people. So there is a change in the way the brain's put together. So what it's telling me, if people aren't getting symptoms typically till they're 50, is the new landscape, the new area. We want to understand why people don't get ALS till later in life. What is the compensated landscape looking at? What are the things that your body does to manage this for 50 years? And let's give you more of that. And let's rescue the people who perhaps weren't born with the same toolbox of those things. So much more important to think about what's going on and why people aren't getting the condition. We all have to have our coloured lines. This is my last slide before a summary. There's neurofilament going up just before disease. I think we know behaviour and cognition does as well. Structural MRI we can see, and functional MRI and MEG. Cellular compensation markers, a bit hand-wavy, but that's the real meaty area I'm very excited about. And left field things that we wouldn't have thought about. Lipids really becoming quite a strong, interesting marker. And I can tell you it won't be to do with, in a simple way, to do with cardiovascular risk. It'll be something much more fundamental in cell management of neurodegenerative processes, I suspect. And so we need to just be much more agnostic, I think, and accept that the things we find might not be interpretable in the framework of the affected patients. So what will happen? In the short term, we're going to be using NFL routinely after you've diagnosed ALS. Just to be clear, after you've diagnosed ALS, not to make a diagnosis of ALS. And we're going to be using it in trials to stratify people, and we're going to be using it, I hope, well, we are. We've been funded to use it in that experts panel. In the medium term, I think we'll have a lot more of these probabilistic models with multiple markers. I think we will develop a TDP-43 pathway-based marker, some amazing, really interesting, exciting data about platelets today from Emmanuel Baratti's group. These are the left field things that you need to think about, actually. We may be biopsying tissues that aren't neuronal, actually, to look for this. It doesn't mean that we have to block TDP-43 necessarily, but if we find we can hook into that pathway, it opens up so much more. The geneticists are not going to be interested in the bad genes anymore. It's all about the hidden hero genes. Okay, more studies of the elderly. Let's get DNA of everyone who's 90 and didn't get a neurodegenerative disease. That's where the real answers are. And let's understand the compensation. In the long term, we'll be going to the larger population for primary prevention. I'm going to stop there. So just to thank the team, everything comes from the clinic. For me, Nigel Lee taught me that. It is a partnership with patients. It always has been. I know that's a trendy phrase now. But it all comes from offering care. If you offer care, the patients will come and then they will kindly let you have all sorts of samples and studies. And then you need young people, and I'm increasingly young, increasingly not young, and so you need young people to actually do the science and have new ideas. People like Michael with, looking at the literature again and finding things that I certainly have missed. Thank you very much.